Next, we've got Pamela Gronemeyer with the Illinois Single Payer Coalition. Pam is also a member of the Physicians for a National Health Program member and a board member of Missourians for Single Payer, and leads Southern Illinois People for Progress. She believes that healthcare is a human right and provides healthcare insurance to our employees and their dependents with minimal out-of-pocket expense, and she is an activist in her community and in the healthcare arena. As the child of a late union laborer, she knows that our safety net is vital to the preservation of our democracy. Let's hear from Pamela.
Yeah, I'm also a doctor too.
Oh.
They let women go to medical school too now.
Yeah.
I'm sorry. That's not the one I want.
Can we hit the button on the other projector?
Just here.
I was up there for a minute. We lost her. I was there for a minute. Where'd it go? Where is Pam Gronemeyer?
We got two projectors set up right now. So this
Well, let's
yeah,
see.
this
Here we
one's
go.
yours.
No. We want Pam. See, and to make it one thing, I have to do this.
Sarah, you are so bad.
I'm not a computer person. You gotta understand. How do I make it just one slide?
Down in the bottom
We got
right
5.
corner.
Okay. Which thing? What's that? Oh, that. Okay. Can you? Is it out of focus?
This is as focused as I can get.
Oh, can't you do this? Here.
Oh, you got that one there too.
Too far.
You got it?
Is it? Okay. Okay, now you got it. Okay. I'm part of the Illinois Single Payer Coalition. We've organized about 6 years ago. Mainly they're people from Chicago because somehow they don't think we know anything about healthcare down here, but we do. Of course, they think that Rockford is also outstate. They also think Rockford's downstate Illinois, so it's like I try to enlighten them. But I'm on the board, and we're trying now to get the word out because we have to educate people. So we developed this whole PowerPoint program, and we're calling it the school year. And we're actually trying to get people who will learn about this, who feel confident enough to give you the PowerPoint, and we'll give you the PowerPoint so you can take it to groups you belong to. Because I mean, that's the only way. It's like playing telephone. We're going to spread the word by getting people to know the word. Which button do I put?
You know, if you go into view, Pam, you might be able to do the slide, the actual slide.
Okay. Okay. So we're going to start. Okay, this is our school. Defining improved Medicare for all. And
That's where it is.
Can you guys see okay?
move it
Mine.
next. Our current healthcare system. Oh joy, it's a lovely thing to talk about. How to evaluate a healthcare system. We worry about costs, access, and outcomes. Costs. Healthcare expenditures is part of GDP. It's probably like 18% now of our GDP, and it's going to go up. People think maybe someday it's going to almost be like 100% of our GDP if we don't control the costs. And this shows you other countries. I mean, and we're going to talk about it a little later, but Canada, there was a time that Canada was right on course with us, but once they developed their Medicare for All plan, it got better. So we have to control costs. Healthcare expenditures per person in 2016, look how much we spend. And do we get, I mean, you honestly can get the best quality healthcare in the United States if you can afford it. But we're talking about, do we get the best dollar for the best product for the buck? No. Why are costs so high? We have no mechanisms to control costs. We have administrative waste and complexity. Okay, price of MRIs, we know the variation in price of MRI and everything. And now, since the beginning of the year, you can go on every hospital's website and look at their charge master. And they're all listed. They tell you how much each test, what they charge. Now that doesn't tell you what deal they made with the insurance company and what they'll take, but you can see the charges. And I mean, quite honestly, I mean, I'm the pathologist, I'm the lab director. When they tell me that they're charging $300 for a lipid panel, it's like, that's not, I mean, no way. And I know we're open 7 days a week, 24 hours a day, But, you know, it doesn't matter what, and we're not gonna get that anyway. We get what the insurance companies pay and what Medicare pays.
That's right.
Hospital costs per day. Look at the average hospital cost per day in the United States. I mean, this shows the average cost and then the 95th percentile, how high it can be.
17,000
Yeah,
is the highest.
yeah. 33,000, 250. Oh, this is for an appendectomy, I'm sorry. This is the cost variation in appendectomies too.
Wow.
Now, I mean, I'll tell you, one appendix is the same as another. And they're not gonna charge you more if it's a retrocecal appendix or if they, and you know, now they're almost all doing appendectomies by laparoscopic anyway, so they're not even making an incision, they're using a laparoscope. Okay, drug costs, Canada versus the US. And we know about this because we saw Bernie over the weekend going with the diabetics to Canada to get insulin. And why? I mean, so many of these drugs are the NIH money has helped develop. And then they've turned around, taken it, and the companies make money off of our tax dollars that we use to create it. Arbitrary drug price increases. I mean, look at what happened to insulin. Look at the EpiPen.
Yeah.
I mean, our friend Joe Manchin's daughter, who runs the people that make EpiPen. I mean, it went up. I mean, then they had a requirement that every school had to have an EpiPen, and then the schools people were looking to get veterinary EpiPens, which are probably the same. And I mean, then also the scam about saying that you don't know what you're going to get when you get a drug in Canada.
Yeah.
It's like, I honestly don't believe the Canadian government is going to let their drug manufacturers make drugs. And a lot of them are made not even in our country that we use and we import here. Why does this happen? Because we have no control. Administrative waste and complexity. Okay. I talk about single payer sometimes, and the problem with single payer, it's a terrible name. And I've actually had poor people, or people come up to me and say, they're single parents. And I guess maybe I say single payer too fast. And it's like, no, it's not single parent. But I mean, the thing about a payer is, all a payer is who pays the bill.
Yeah.
Okay, so now, this is the mess we have. Employer-based private insurance, which is an anachronism. It began during World War II when they couldn't raise wages because there was a price freeze on wage freeze. So employers started competing with each other by giving them better benefits. So it's an anachronism. Medicare, Medicare Advantage, Medicare supplements, Medicaid managed care. And I mean, we know this is the anniversary for the 54th anniversary for Medicare. And it was signed today in the Truman Library, and the first person who got his Medicare card was Harry Truman. Because Lyndon Johnson went there to sign it. And when they passed Medicare, there was an effort to get Medicare for everybody. But it was hard enough to get Medicare because if you ever had a chance to hear the Ronald Reagan recording he made for the AMA about how communism is going to come to your town and you're going to, because of the Medicare, okay. So they couldn't get Medicaid, they couldn't get Medicare for everybody, so they got Medicaid. The problem with Medicaid is co-funded by states and federal governments, and the states can't operate like the federal government does. So it's always going to be less, and it's always going to be in trouble. The ACA health exchanges, the CHIP plan, student health plans, the VA, and the Indian Health Service. And now the VA and the Indian Health Service are really more like a national health system because everybody works for it and the facilities are owned by the government. Right. And you know, when Britain went to a national health system at the end of the war, I always believe it was because they thought that any person in England could have been hit by a bomb when those German bombs came over, and they realized they were all in the same boat. And even Winston Churchill, who was a known conservative, supported it. Right. And even though they try to take it down and they try to starve it for money, nobody is going to get rid of the national health system in England. No. The same way Canada, even though they try to starve some stuff in Canada, they still keep going. This is our current healthcare system. What a mess. Well, see, we have more than a few payers, Medicare, Medicaid. I mean, it's not single payer. Overhead costs by insurance type. This shows you how much different. This is the administrative cost for Medicare. They estimated 1.8% for a private Medicare. That's the supplemental, that's the managed care. And for combined private, I mean, we're paying for their advertising. I mean, and then there's only so much they can use for advertising. They have to, the ACA required them to give so much for actual medical benefits. But you know, I mean, look at the salaries the CEOs make. I mean, we're going to get to that. Incentivized to care for the wealthy. Different insurers reimburse at different levels. And I mean, they not only reimburse at a lot different level, they change your reimbursement. When you're signed up for a contract, if you don't watch them, they'll try to drop your reimbursement. I know that from my bills. Medicaid pays the lowest. Medicaid in Illinois pays, but it's really low, and that's why doctors don't take it. I mean, it's because realistically, sometimes I don't get paid for image cytology for GYN. I don't get paid what it costs me, but I get paid a little bit more for some of the infectious disease testing. Medicare pays more. Private insurance pays the most. Theoretically, it's a multiple of Medicare, because every year Medicare publishes a fee schedule, and it's based on a formula which includes how much the practice expenses are, how hard it is, how long it takes you to do it, and how much expertise. So it's really, they've tried to arrive at something that makes sense. But the insurance companies look at that and adjust their payments as supposedly like a 1.4 or 1.5 or something, but it's really not that either, because if you watch them, they'll go lower. Okay, hospitals try to optimize their payer mix. Why do they move? They don't move because, you know, we're going to talk about ones that moved. St. Mary's Hospital and Street are closed. Well, they're closed. It was bought by PR. So the OSF, I guess, bought it. Kenneth Hall closed, which used to be St. Mary's in East St. Louis. It closed. Jackson Park, I don't know. St. Elizabeth's in Belleville. Belleville has a pretty good population, and there were 2 hospitals in Belleville. But St. Elizabeth moved out. I mean, it's not the center of population, trust me, where they moved. They moved out near Scott Air Force Base, Fallon. So they, I mean, it's payer mix. And you know, that's something you learn when you work in the hospital, is payer mix.
Jackson Park. So the labor and delivery, the electrical services at Jackson Park. I think the first thing that people should know, this is in the South Shore, which is predominantly African American. Jackson Park, the salaries for the executives at Jackson Park there are 3 of them. They run almost $3 million a year. What? They give themselves $25,000 quarterly, just because it doesn't matter how the hospital is performing. But they're about this service is due to close on August 4th. So we tried to get the governor to keep it open, but we couldn't get a response. The really positive thing about this is that the entire medical staff, as well as the nurses, are all black and they're all women. And they work there. That is nowhere else in the state that you can find that.
Wow.
Where the staff is all women and all black, and they made many proposals to the hospital to figure out how to attract patients, because that's one of the things that they said they were going to do. And the Illinois Department of Public Health says that area is going to be a healthcare emergency. The closing of these obstetrical, that area will become a healthcare emergency with the closing of these.
Look what's, I mean, right now the big thing with Hahnemann too in Philadelphia. Hahnemann is a big community, a big hospital in Philadelphia that's in a poor neighborhood, and it was bought by venture capitalists who, we're going to keep it open, ha ha ha. Well, now they're going to close it, and theoretically they're going to sell the real estate to make condos.
Warren has a plan for that.
That's awful. I mean, it's this thing is, and I mean, when venture capitalists get involved, trust me, they're not trying it to keep the hospital alive. Yeah.
Okay, you mentioned the word pay or miss.
Payer mix, PAYOR mix. That means
Mix as a mixture
of the payers, right? How many Medicaid, how many self-pay, right? Okay. Or meanwhile, urban and rural hospitals. Oh, I already did that. Sorry, guys. Okay. Excess. The U.S. still has 28 million people without insurance. That's after the ACA. 28% of working Americans were underinsured. And being underinsured is, what good is it? If you have it, you can only use it for catastrophic. You're going to get catastrophic when you could have had something that was preventable. And that's just a crime. The number of children without coverage increased for the first time in 8 years. That's because they're playing around with CHIP. 3.9 children in total without insurance. And I mean, that's criminal. I mean, I guess when you're a baby, you're supposed to have a job when you're born. Either that, I mean, that doesn't make any sense. I mean, and I mean, a lot of people, they worry about abortions, and then they won't worry about the kids after they're born. But they don't care about them. Okay. More bad news, 67% of those filing for bankruptcy actually had health insurance. 70-80% of these had private insurance when they became ill. 57% who lost their homes to foreclosure identified medical debt as a major cause. It's gotten better, but it's still there.
Yeah, that's right.
Average contribution to premiums, it's going up and up and up and up and up, how much we pay for our premiums, if you had it through your employer. I mean, the hospitals used to be classic places where people got good insurance.
Yes.
Now in the hospital system, they're making their $5,000 deductible for their employees.
Yes.
I mean, that's terrible, $5,000, who has that extra $5,000 sitting around? And I mean, then if you're sick, on top of it, you're sick, then you have to pay, then they say we don't put skin in the game. Deferring care due to cost, percent of adults ages 19 to 64 who reported any of the following cost-related access problem: had a medical problem, didn't visit, did not fill a prescription, skipped recommended test, treatment, or followed, and didn't get specialist care. I mean, the young diabetics now, they're trying to skip eating so they don't raise their glucose, so they don't need insulin, and that's not, it's killing them. I mean, this is like, we can do better. I mean, I always tell people, I believe that our country is only as strong as the weakest link. And it's our job to take care of that. They want to send our kids off to war. They want us to do it. They want us to be, they want us to work and be productive. But if you don't have your health, you can't do that.
That's right.
The ultimate sacrifice. And I mean, this is criminal too, because most of these, California has a huge population. So they're always going to have people, but Texas, Florida, Georgia, they didn't expand Medicaid. And that money was sitting there in the ACA that they could expand, but they were just mean and didn't expand it, which is so stupid. I mean, and their rural hospitals needed that Medicaid money. So that's why rural hospitals are closing, because they can't stay alive without the Medicaid. 23.5% of our state budget goes to Medicaid. Starting in 2011, we have a managed care system. And we all, managed care was, we remember in the 80s, managed care, the goal was to manage to not let you see the doctor. And I mean, it's still, we're paying private insurers to handle Medicaid. And the theory was with Medicare Advantage too was you're going to have better outcomes. The outcomes are no better. And then the theory is too, you hear this all about Medicare fraud and abuse. Well, I saw an article this week talking about the fraud and abuse in private insurance. It's out there, they just don't talk about it, they cover it up. Nearly, these MCOs make a profit by denying care and having extremely limited provider network. They're also limited because they're Medicaid. And that's why it's so hard to find a specialist, because they pay really badly. I mean, but you do have people that will do it. And I mean, they ultimately pay. It's just pretty low. And I mean, like, I'm a pathologist in a hospital, so I have to take all comers. I mean, I don't look, when they take when the surgeon does something, I get it whether they can pay or not. But that's the right thing to do. I mean, I didn't go to medical school to become a millionaire. I'm probably good, because I didn't become a millionaire. Preventing deaths due to treatable conditions out of 19 wealthy countries, we're 19th. Mortality that could be prevented by good medical care out of 195 countries, we're 81st.
Oh
Life expectancy, we're 25th. And the last few years are the first time we've seen life expectancy in elderly white men go down. I mean, they were living longer, but not now. And I mean, part of it is like suicide and smoke. I mean, but Americans in general did pretty well about smoking. But I mean, we could do better.
Yeah.
Maternal mortality is rising here and not elsewhere. And we just had in one of my hospitals, a girl came in, 19-year-old girl, who said she didn't know she was pregnant and delivered, she was 34 to 36 weeks and delivered a dead baby. Okay, and we know income racial inequalities. And that's not only health care, it's also related to food, where you live, what kind of housing you have. I mean, it's all related to other things, but we know that there's still incredible disparities in healthcare outcomes in healthcare because of your race and the economic status you have. Outcomes, how do we measure up? Okay. Did I skip something? How do we measure? We don't do real well, because this is how much we spend. And actually, I think this is really where our life expectancy is compared to the other countries too. But look, we're out here, and you really don't want to be standing out in left field or right field, whatever. Everybody else does better. And I mean, the only problem is you've got to watch what you say to some of these people who want to argue with you. If you start attacking the quality of American health care, they'll jump your case. But if you have money and you can afford it, you can get the greatest care on earth. I mean, Mick Jagger came here to have his open heart, but it's not, on average, it's not great. Our solution is single payer, covers everyone for birth to death. I like womb to tomb, but birth to death's okay. Comprehensive coverage, including payments to medical, preventive, dental, and these are the new programs that Jayapal came out with in the beginning of the year in Bernie. Because now we're talking about payments for dental, vision, hearing, long-term care, which were not included in the original HR 676. HR 676 was written by John Conyers many years ago and was the single-payer bill for a long time. But Jayapal, who comes out of Washington, a congresswoman from Washington, she rewrote it and got a lot of input from people and included all these things. Because we're not talking about Medicare as it is today. We're talking about improved Medicare. We want, and see, that's what you got to tell seniors so that they're not afraid. You know, they know Medicare works, but they get scared because they hear everybody saying they're going to have more lines, longer lines. Okay, no cost sharing, no co-payments, no premiums, no deductibles. It's paid for by one national fund, but care provided by private institution. So it's privately delivered, but publicly funded. And but it's not free. So never let people say, well, you can't have free health care. Someone pays for it. But what we envision is a system where people who have more pay more. I mean, they've prospered in the United States. So, I mean, our income taxes now are lower than they've ever been. I mean, and, you know, it became a horrible disease, you know, taxes. I always thought it was just a part of living in our country. But, you know, you hear everybody talking about, oh, taxes. But, you know, you're getting something for your money. They pay more taxes in Canada, but they get something for their money.
Right. That's right.
So, because we need Medicare to be improved, okay, dental, vision, hearing, also has hearing. And the new, I didn't make a copy of the new one, but it has hearing because some lady pointed out that we didn't have hearing. But it's in there too. Remove costly cost-sharing premiums, co-pays, deductibles, and you won't need supplemental. That's why you won't need private insurance. It also gets rid of the private managed care plans. Okay, single payer, how it works. And just like when you're born, you get a card. You go in with your card. You don't have 8 people in the accounting department when you go to the hospital. I mean, you just show them your card. You don't have to pull out the card 8 million times. It just makes sense. And I mean, for us, every doctor spends about $80,000 plus a year in billing. I mean, I have my own biller, and I mean, I pay her salary, I pay her health care benefits, and she has an office. But it would be much simpler. I mean, I can write a clean claim of Medicare and get paid in 3 weeks. I mean, insurance companies play forever. Plus, they also pit you guys against the doctors. They'll tell the doctors the patient didn't do something right. They'll tell you we didn't do something right. So by the end, everybody hates everybody. Oh, here we are back again. Isn't it wonderful? It also looks like a Rube Goldberg, doesn't it? Sort of like a Rube Goldberg where you take everything and put it together. Benefits of single payer: increased efficiencies, reduced waste, more effective in negotiation, lower health care costs, government accountability. And see, government accountability does not mean you're going to have a politician and bureaucrat determining what your health care is or deciding on your health care. And that's what all the ads that are going to come out from the Partnership for America's Healthcare Future are going to say that a politician or a bureaucrat is going to decide what health care you're going to get, and that's wrong. Your doctor is going to be making his decisions, not the bureaucrats or the politicians. And maybe the AMA would be better served if they would lobby to get better benefits for their patients than worrying about joining the Partnership for America's Healthcare Future. Okay, improve financial stability, care will be more equitable. Reduce provider burnout, no medical bankruptcies, transparency, healthcare not tied to employment. And they talk about, well, this is going to upset the system. You know, 66 million people change jobs every year, which means once you lose your job or you change job, you have to get new health care. And I'm a small business owner. Every year I get and I have to have United Healthcare because my area in the Metro East, that's about the only person I can get. Every year I have to decide what my employees are going to get, what I pick out, and that goes, their raises go away. I mean, because in general, if it's a good year and they have much of a percentage increase, but last year was 8.6% again. And I have 8 employees, and they pay no premiums. I cover the premiums for them and their dependents, and I get as low a copay, low a deductible as possible. For the last 2 years, I got they had no deductible. Now, the cheapest I could get was, I could get a 500 or 1,000, but if you looked at the 1,000, it was better because it was less out of pocket. But I mean, and that's awful for me because I'm using their raises. I guess I could go and say, what do you want? But then, you know, I think the most in general, they appreciate the health care. So, I mean, I hope so, because I have great retention. And also, I mean, the other thing is, as an employer, the older they get, the more they cost. So does that mean I'm supposed to fire them because they're getting old? No, because they're good employees. They make my business. So, okay. Oh, this just shows you that split. What happened? Canada, how much it cost them versus us. We kept rising, and this is where Medicare was instituted in Canada. And Medicare in Canada is really not single payer, it's provincial payer. So each province is different. And it started out in Saskatchewan, where Tommy Douglas, who was an immigrant from Scotland, who came in and had a defect, he had some sort of problem with his leg, and he was poor. But some doctor felt that he should operate on people even if they didn't have the money. So Tommy Douglas got operated on, and he believed in single payer. So in Saskatchewan it started. The first month, all the doctors went on strike. I mean, it was a disaster, but theoretically a disaster, but they got together in Saskatchewan and figured it out. Plus, they didn't realize that if you were licensed as a doctor in Britain, Great Britain, you could come and be a doctor in Canada without getting a new license. So there were doctors who came from Great Britain to cover the need. Within 1 month, the strike was over. Then once people saw how Saskatchewan worked, the other provinces joined. And I mean, that's why Tommy Douglas was voted the most beloved Canadian politician of all time. And he's Kiefer Sutherland's grandfather, so. Is there single payer legislation? HR 1384, that's Pamela Jayapal on February 27, 2019. She may have more than 116 co-sponsors now. Medicare for All, that's Bernie's act. Bernie had an act that came out I think it was last year, 2017, and it wasn't as good because he didn't include long-term care, but now it's been rewritten. The only thing is they have a different phase-in. His talks about a 4-year phase-in. Jayapal's talk about a 1-year phase-in. The first year, all people on Medicare get improved Medicare, and then the second year, we're all eligible. But Bernie's phases it in by, you know, I think it starts out, goes to 55, and picks up all the kids, and then it's a little more confusing. But the problem is, too, that they're trying to deal with the fact is there are going to be displaced workers who work in the insurance industries. Not the CEOs, we don't care if they go, but it's the other people. We'll say adios to them. But it's the other people, but part of these bills include retraining. And I'm from Southern Illinois, and we closed a lot of coal mines. And those coal miners got retrained. I mean, in two of my hospitals, the coal miners, one's a lab tech, got an MLT degree, and the other one became a teacher and taught German up in Springfield. So, I mean, realistically, and there will be more needs for people in healthcare. So, I mean, it just you know, and I mean, they also say they didn't ask farmers, they didn't leave it up to farmers to decide whether they should have technology. Technology came and there needed fewer farmers. So, I mean, it's sort of, I mean, technology can't hold us back, so we will figure it out, but there's money to retrain people on those bills. And this is the difference in the bills. And, okay, any resident of the United States, any resident, it doesn't say, I think the citizen thing is a little bit strange, but right now it says resident, yeah. And I mean, gosh, that really drives the GOP crazy if they talk about, you know, non-citizens getting health care. But you should see how much the non-citizens contribute to the Medicare and Social Security. I mean, because they're all paying in because their employers have to take it out, but they don't get it. So they are paying in now and not getting anything for it.
That's a shame.
All medical necessary cause, and then, but now the new one with Bernie does include long-term care, and Bernie has a co-payment of $200 for drugs, which is sort of strange. I don't know. There are a few things that are different. It hit 2-year versus 4-year. There are differences, but you know what? These are just the beginning. They're not gonna vote on
I
this.
love that. Oh, I love it.
Oh gosh, if you watch those videos from the Partnership for American Healthcare, they're gonna be taking taxes from everybody. I mean, we haven't really decided how we're gonna pay for it. And they're also, you're gonna hear, they're gonna, because you give people free healthcare, everybody's gonna be flooding the hospitals and flooding their doctors. I mean, as far as I'm concerned, I don't know too many people who really wanna go to the doctor. Sometimes you have to push people to the doctor. So I can't really see, you know, and right now Americans go to the doctor and are in the hospital less than anybody else in the world. Covering the uninsured is going to cost more. Medicaid rate adjustment, because what the goal is to raise Medicaid to Medicare's rates, so that makes it better, because then you will have less doctors grousing, and they're really, doctors want Medicare for all. I mean, they did a survey in 2001, I think, and at that time it was a lot lower. Then they repeated it in 2011, and I mean, the average, pediatricians or psychiatrists were up to 85%. Pediatricians, I think, were in the high 70s, and most general care, like family practice, internists, general surgeons, pathologists, and we weren't even included in the first survey. They didn't even ask pathologists in 2001, but they asked us then. We were all included in it, and it was like 57 to 60% at that time in 2011. And the only ones that were like the outliers, I shouldn't say this, were the radiologists. They were at 37%. Radiologist.
Oh,
I won't say anything about shadows. Okay, you'll save money in provider administration, insurance administration, government administration, and you're going to increase market power. Net savings, they're estimating, I mean, these estimates are not totally, because I mean, we don't know what's going to happen to the usage, but there's going to be a savings. And even, okay, and there are two studies. The Mercatus study was one that the Koch brothers funded. And that one showed that it was a $2 billion savings, which they said, well, maybe that wasn't right because we didn't count all the increased utilization. But the Perry study, which came out of the University of Massachusetts in Amherst, also showed a savings. And I mean, what's going to happen is, instead of people, well, you could pay it by many different ways. I myself would prefer like an employer tax that I pay that will replace the premiums I pay for my employees, which they say will be like 8.6% less than I pay now. And also, I think, because you're paying a little bit for Medicare, I think they're paying the charging employee, but it will be less than their co-pays and deductibles, their premiums. So I mean, it will be, but we're not talking, it's also going to be adjusted on a progressive thing, also progressive scale. You also could, you know, tax Wall Street transactions, which would be good, you know, for a Robin Hood tax. Or you could also, I mean, you can start, I mean, do stuff with raising, you know, doing a progressive tax starting at above $250,000. There's a whole bunch of ways you can do it. But we just have to believe it can happen and push that it can happen. When funded single payer will increase income for the 95%, it's not going to take your money away, it's going to give you money. And it's going to give you health care. But why, oh, and then I will just talk about this for a second. The modern monetary theory, which is the idea that since the government prints money, we never worry about how much the defense budget's going to cost. We just pass it. So why are we even worrying about this? Now, I don't think this washes well with Republicans, because they're just going to say you're going to drive us into inflation. But a lot of people, they're economists, and that Stephanie Kelton, who's up in New York now, she used to be at the University of Missouri I think in Kansas City, but she's a big proponent of this. But I mean, I'm not sure, and somebody in the Illinois Single Payer Coalition is an economist, and he really is promoting it, but I don't think it washes well. The U.S. government, here, this is the modern monetary. When Paul Ryan asked the federal, pay-as-you-go benefits are not insecure in the sense that there's nothing to prevent the federal government from creating as much money as it wants and giving it to somebody. Okay, and this is just about, I'm not sure I believe it, but we spend an exorbitant amount of, well, I mean, but you know, these are a whole bunch of theories on how to pay for it. We spend an exorbitant amount of the healthcare right now. This is because our system is flawed and inefficient. Moving to single payer will undoubtedly cut costs. Any additional costs incurred by the government to implement can't be paid for with or without raising taxes. Moving to single payer will make the economy more efficient and gives its people health care. Because health care is a human right. Why do you have to be born? I mean, why does a baby have to have money to pay for his health insurance? Give me a break. None of that makes sense. So that's it. And like I said, if anybody would like, after watching this, would feel comfortable, we have a sign-up sheet, and we will give you the PowerPoint, and we'll work with you to help. I mean, because you know other groups that I don't know. And even, I mean, even if you talk to somebody in the supermarket.
Yeah.
Well, I mean, that's the only way words are gonna go, is the supermarket everywhere.
I like that.
Yeah.